Thank you for joining us for the Frontiers in Child Health Research Seminar. The seminar is held on the second and fourth Mondays from September through June and includes speakers with work focused on child health from both UCSF as well as guest speakers. Please let me know via email if you're interested in speaking or would like to suggest a speaker. Looking ahead to our next speaker, we will be welcoming, oh my gosh, sorry. One sec. All right, I'm just going to call this right now. Hello?
I can introduce myself too. I know a lot of people. I'm Adam Numis. I'm one of the pediatric epileptologists, and I do a combination of clinical and translational research. And then my clinical focus is kids with intractable epilepsy with a focus on neonates and infants. And so the title of my talk today is going to be Genetic Testing in Neonatal and Infantile Epilepsies, with a goal towards talking about precision medicine approaches that currently are on a research basis, but should be more in the prime time in about five to 10 years in that kind of window. So not a pipe dream away, but really in the next 5 to 10 years. Disclosures, unfortunately, nothing from industry really, but nothing that is really pertinent to this. It's mostly just funding agencies. And so the learning objectives for this talk are to go through some of the electrical phenotypes of what our early onset epileptic encephalopathies are, and talk about some of the genetic testing that's available and how we utilize that, and then how precision medicine is playing a role in this, both on a research and clinical basis. Just some definitions. So epilepsy itself, 2 or more unprovoked seizures greater than 24 hours apart, that gets you a diagnosis of epilepsy, which includes our head of the Supreme Court has epilepsy. I mean, it's a very common disorder, affects about 1% of the population, skewed towards either end of the lifespan, earlier onset in the neonates, infants, and then again once you get above 60. The caveat is you can have the diagnosis of epilepsy with just 1 seizure if you have risk of epilepsy. So let's say you have a stroke, brain injury, trauma, and you have a seizure after that, your risk of having another seizure is over 60% in the next 10 years. And so you actually qualify as having a diagnosis of epilepsy, which matters when you're discussing about treatment options and things along those lines. The other word I'm going to be using quite a bit is epileptic encephalopathy, a developmental epileptic encephalopathy. So these are conditions, so epilepsy, but where the EEG changes, where our interictal EEGs, where you just see a lot of extra electrical activity, actually contributes to the phenotypes as well. And so your intellectual disability is really not just related to the seizures, but actually what's going on in between those seizures. It's an important sort of concept as we kind of think about these early onset epilepsies. All in causes of epilepsies, looking more recently, we're learning that a lot more genetic etiologies are there. We used to call it idiopathic, which was, even when I was in medical school, defined like the majority of our epilepsies are now really being understood to be either related directly to a single gene or epilepsy association genes. And so even people with acute symptomatic seizures related to a brain injury, there's genetic polymorphisms, there's genetic gene associations that increase risk of epilepsy, which is why some do and some don't. So those are really being understood much better over the last 5 years. All right, we're going to focus really on neonates and early infants and under 6 months of age. In the neonatal population, if you had to guess sort of what is the most likely cause for a seizure, lots of cohort studies have been done. I'm focusing on one for Europe because I can't use all of our UCSF data all the time. But our UCSF data matches, neonatal seizure registry throughout the country matches. If you had to guess and you said, oh, that kid is seizing in the neonatal ICU because they have HI8, you're probably more likely right, because it's more than 50% of the time. This is, study after study after study. Genetic syndromes account for a minority of causes for seizures in the neonatal period, but it's an important one because they're treated differently. And again, the implications for precision medicine are quite different. So we think that they accompany about 1 in 20, 1 in 40 in that kind of ratio is about what we're seeing for genetic epilepsies in the neonatal period. Look at this in a sort of pictorial sense, right? HIE is the predominant reason why kids seize, baby seize. But again, that genetic contribution is there. And you can see that there is in fact an overlap between, just because you have HIE doesn't mean you also don't have a genetic cause for your seizures and your epilepsy. And that's something that we're actively studying. So why do genetic testing in these kids who do seize? Prognosis, recurrence risk, right? Things you do genetic testing for in any disease. Importantly, clinical trials research, precision medicine, I think is the really important one that you guys have taken up in a lot of other fields in pediatrics, but has been a little bit slower in the neurology space, but we're getting there. Importantly, I think too, what we've learned is, there are lots of different tests that we can do. Clinical geneticists are really spread thin. Invitae is across the street, and they pay better. They give people free lunch breaks, and you get exercise breaks. And so it's hard, in an academic center across the country in neurology, at least we know that, getting access to clinical geneticists is becoming harder and harder. And so we have to take the onus on ourselves to learn how to do this, how to order tests, how to interpret tests, because it's not fair to patients to wait 6 to 9 months or 12 months. And that pipeline's not getting better. Academic salaries are not increasing the way Invitae or GeneDx are paying. So it's important that we kind of start to think about how to take this on a little bit better. These are the different tests we use. In epilepsy, we really start with targeted gene panels. We'll get into why, followed by microarrays, and we're starting to get more and more towards genome sequencing, at least on a research basis. For cost, I think, we used to think that these used to cost so much. If you are in the neonatal ICU, in terms of what these are relative, SNP microarray costs the same now as one serum amino acid panel. So all the tests would do to bleed kids out with amino acids, organic acids, molybdenum, all of that stuff. Each one of those tests, a microarray costs about the same. Also, cranial ultrasound costs about the same as a microarray. If you're thinking about a gene panel, arterial line placements, same cost as a gene panel. So they're not a ton of money anymore. And these are CLIA-approved labs getting you a clinical report, not research costs. Whole genome sequencing sounds like it's really expensive. It's the same as an MRI brain without sedation. So we order those comfortably, but yet we think of these costs and just relatively what it is. If you want to compare that to a video EEG, how much the hospital charges for a day of video EEG monitoring, whole genome sequencing is about a fifth. So a fifth of a 24-hour video EEG is what a whole genome sequencing will cost. So the cost have really come down and shouldn't preclude our ability to order. So how good are these tests, right? How good are these tests in neonates, infants? We'll kind of go through that now. Again, in epilepsy, there's no consensus on what you should do first, but the majority of us who are doing this are starting out with targeted panels. And the reason is it gives us the best chance of success. So all comers, there's been several studies. I'm highlighting one of the earlier ones that looked at the diagnostic yield of targeted gene panels in kids with epileptic encephalopathies. So diagnosed with severe epilepsies within the first year of life, and then cross-sectionally, they got genetic tests later on. And the yield from this study and a series of studies after, basically there are a few a year now, tell us that the yield of these tests is about 30%. So if you do an epilepsy gene panel in anyone, focal epilepsy, generalized epilepsies, it's about 30%. If you look at the kids who are youngest, so who develop epilepsy in that neonatal period in the first month of life, that hit rate goes up to 60%. And so it's important to know that it's not 100%, but you're getting quite a bit in there. Time after time in these studies, we see the same genes implicated. So our gene panels now with epilepsy incorporate about 200, 250 genes, depending on which company you go through. And a lot of those genes are it's the same ones you're looking for. Unfortunately, in neonatal infantile onset epilepsies, it's really just a couple dozen genes that you're really looking for. And those are the ones that really have described syndromes. We've kind of moved past the discovery phase for these early onset epilepsies. We know what people have. If we don't find the answer, it's probably not because there's a new gene somewhere. Although that's possible, it's that our genetic tests aren't quite good enough yet. And so I think what we've learned is, the yield of pathogenic genetic variants in kids with these early onset epilepsies, especially with the epileptic encephalopathies, is much higher compared to children and other older adults with epilepsy. So 60%, not bad. Again, there's a limited set of epilepsy symptoms that occur in the neonatal or early infantile period. Some of the most common we're kind of going to be talking about. But if you saw a kid with a neonatal onset epilepsy, and someone quizzed you, what could this be? If you said KCNQ2 or SCN2A, not that you may remember those, but if you can, you'd be right a lot of the time. So those are the two most common, but there certainly are others. And these are common causes of a rare type of epilepsy, right? But there are lots of other causes. You might have heard of Ohtahara syndrome. Doesn't always have to be genetic, could be a cerebral malformation. So an MRI, genetic testing is going to get you an answer there. And some of these are all included in our epilepsy gene panels now. If your epilepsy panel is negative, what we're often doing, just so you kind of know what our workflow is becoming in pediatric neurology and from the epilepsy standpoint, right? So we do our gene panels. If we do get a negative response, the next step is our copy number variants using SNP microarrays. What we're looking for on these isn't necessarily like the 1Q 21.3 15 something variant, although that's important. It's probably not what we need to know in epilepsy because that's not going to be helpful. What we're really looking for is looking at microduplications and deletions in those epilepsy genes that I mentioned in the epilepsy panel. And when we think about that, this gives us another 5 to 10%. So in those early infantile epilepsies, if you combine a gene panel with a microarray, you're getting yourself towards 65% in sort of understanding these diagnoses. How about exomes? So they're important. They used to be more important, but we used exomes quite well to identify these genes that we need to incorporate in gene panels. And so at this point, at least for epilepsy, exomes cost more, don't really provide much more benefit, and have a lot more variants of uncertain significance on them that make it harder as an epilepsy provider to really help. That's when I need, if there are VUSs in genes or syndromes that I'm not quite sure of, I need a clinical geneticist to kind of help me. But if I'm able to limit my testing to the things that I know, then maybe we don't necessarily need a geneticist for every single diagnosis, which again helps open that bandwidth for other people. So here's just this was a study just last year. So this is looking at kids who had targeted epilepsy panels and then exomes. And so the number of kids who had pathogenic variants, about 65%. The number of kids who got an additional diagnosis from an exome was under 4%. And now that we've kind of added genes to our epilepsy panels, it's closer to 1%. So the exomes, while they do provide some additional benefit, it's much more modest. And again, the number of VUSs you're going to get that are hard to interpret, understand, and talk to parents about increases significantly. Whole genomes, how is that going to be incorporated into our practice? Again, right now it's a research basis. No insurance company is paying for it for epilepsy, at least. But I think this is where we're going. And whole genomes, right? 99% of our DNA is intronic, not exomic. And so understanding how to use this is going to be interesting. The way we're starting to do this on a research basis is instead of looking at the entire genome, which is very complex, and you're going to get a lot of VUSs from it, you can actually ask companies to do targeted genomes, right? So if I know the 200, 250 genes associated with epilepsy, do I need to look at everything? I mean, yes, we don't know where every transcription factor is, every regulatory factor is. We don't know it now. A whole genome isn't going to tell us that today because we don't know where those are. But if I give them a list of targeted genes, they can look in the intronic DNA around those genes to help us understand if there's, indels or deletions or, single variants that may have somehow tied to those genes. So I think that's sort of our next thing. It's not necessarily just whole genomes, but maybe targeted whole genomes, again, so that we can help talk to our patients about this without having to burden or already overburden clinical geneticists. How are they doing so far? So how does whole genome kind of compare to what we're doing? It's still sort of the infancy of this, at least in the neurology space, and particularly epilepsy space. This is a study that was done last year, published last year, that was looking at whole genomes on 30 kids with developmental epileptic encephalopathies who did not have a diagnosis after exome or microarray. Targeted gene panel or microarray. So 30 kids, negative gene panel, negative exome, and about 13% of them, so about in that 10 to 15% range, had a hit based on this. And those were either variants in intronic DNA near one of the epilepsy genes or larger rearrangements that you really can't detect on a targeted gene panel. We're limited still because we just don't understand how to interpret this data, right? It's how we were with exomes, at least in epilepsy, about a decade ago. We kept on doing them. We got more information. We're able to reclassify things. And that's kind of where we're going to be at as we start to get this done on a research basis. The tough part is the NIH, at least in the NINDS, our neurology version of the NIH isn't super keen on funding these studies right now. So it's unfortunately, it's asking, very people who can help us with philanthropy to really get these studies going. So at least in the neonatal ICU, right? Hopefully you have a neurologist nearby that can help you, but not every neurologist is on this meeting right now. So it is on us to, all of us as pediatricians to think about who we should be sending testing in. And in at least the neonatal ICU, the seizure semiology and the EEG findings really help guide us through this. As an epileptologist, I really think of seizures as sort of when did they start? Was it a premature infant? Was it a term infant? And whether their seizures are more acute symptomatic or are they presenting more like an early onset epilepsy. Getting into what do seizures look like. So just going through some terms. These are terms that were developed in the 80s by Volpe, if you know that name. He classified seizures into 4 categories: subtle, tonic, clonic, and myoclonic. We use that classification for 40 years. Now in the pediatric and adult epilepsy space, we changed you may know this, right? We've renamed absence seizures a few times, focal seizures with impaired awareness, which used to be complex partial. Those names change every 5 years. But in the neonatal space, we use the same terms for over 40 years until, fortunately, last year, it was rebooted. And through a series of Delphi processes, we were able to come to a consensus on how we should be potentially talking about these in terms that more effectively kind of correlate with what we use the same terms in children and adults with seizures. So as opposed to just calling everything subtle, now we can be a little bit more descriptive, and that does actually help us in terms of understanding etiology. So we now use motor and non-motor seizures the same as we do for children and adults. And we classify them as clonic, which is, fast phase, slow phase, fast up, slow down. Epileptic spasms, which are more that kind of jolty kind of movement. Myoclonic, rapid jerks. Tonic seizures, stiffening. Automatisms can be anything from chewing movements, subtle hand movements, and then your non-motor seizures, autonomic. So usually this is a color change most frequently. It could be repeated hypertension, unlikely to be apneas, although that can happen. Or just overall general behavioral rest. So paucity of movements that are repetitive over and over. And so this is a video of a baby seizing in our unit a little while when I was training. And here you can see some automatism as well as some autonomic changes, right? You're seeing the lips turning blue there. So this would have been classified as a subtle seizure. Now we classify this as a motor seizure with automatism. And again, it's helpful as we're thinking about etiologies, because if you label everything subtle, then it's hard to really figure that out. There's some other descriptors you may just see us starting to use in our notes. And again, this just came out last year, so we're all trying to learn it in the neurology space. And hopefully as we start to use it more and more, it will become more sort of second nature for everyone on this meeting as well. We're getting there. It took 40 years for us to modify it. It will take a little bit of time for us to use it more, but it's good because it really does help us tie in more with etiology and sort of treatment paradigms. Briefly, EEGs in the neonates, as opposed to what we do in kids and adults, it's a double distance. So because their heads are smaller, we use half the number of electrodes. So instead of 22 channels or 22 cerebral electrodes, we're talking more like 10. Here we do 10. Some institutions use more. The minimum number is 8. So instead of having, just to orient you as these EEGs are going to look, this is a left temporal chain going from the front to the back, a right temporal chain going from the front to the back, something called a parasagittal chain, so going along the midline, and the right parasagittal. And for a neonate, we just take out some of those electrodes. So we still do sort of a central temporal, it's just we connect them in a little bit different way. And it's important because those limited channels will help with scalp protection, so we're not sort of scratching the kids' heads all the time. It helps with prevent skin breakdown and also helps us with our EEG signals. Backgrounds do evolve quite a bit. And that's important because when we're looking at neonates and infants with EEG, knowing the age is critical. You can see here, this is what an EEG, a representative EEG from 25-weeker, when we monitor them, it's almost like a burst suppression pattern. Sounds pathologic, but that's normal for a 25-weeker. If I looked at someone with this EEG and they were termed, that would be severely abnormal. At 28 weeks, you move from that burst suppression pattern to getting a little bit more waveforms. You may remember some terms like delta activity or 1 to 3 hertz activity. So frequencies, there's a richer admixture in there. Your amplitude EEG kind of goes from that burst suppression pattern. You start to see some cycling or the starts of what will be sleep wake cycling later on. And then when you get to 40 weeks, during wakefulness at least, you have a continuous EEG with lots of different frequency admixtures in there. And that background evolution is very helpful. And so in the epilepsies I'm talking about, these early onset epileptic encephalopathies, right? So if you have, these genetic disorders, your term EEG looks more like this or this. So even though they're not premature and they're born term, your EEG kind of is dysfunctional. This also happens when we have acute brain injuries, whether that be from stroke or hypoxic-ischemic encephalopathy, that can happen as well. And so truly knowing whether this particular EEG is normal or abnormal is really dependent on the age of that patient. So in a term neonate, totally severely abnormal. In a 26-weeker, totally normal. And this EEG is really what we'd be expecting to see at term or term equivalent. The seizure semiologies and EEG findings do guide us. And just to walk through some examples, this is a newborn that I take care of, we diagnosed in my training. 36-week infant, and as soon as she was born, about 24, 26 hours of life, head, eye, mouth extension, occurring multiple times per day. This is a video of her seizures. Neonatal seizures are interesting in that they typically don't happen once, right? There's one of my mentors learned the phrase like neonatal seizures are like potato chips. You can't have one. I'm certainly someone who can't have a single potato chip. And neonatal seizures are that same flavor. They happen over and over and over and over again, which is why we tell people, call us once it's happened 2 or 3 times, because neonatal seizures really will continue to happen, whether that be acute symptomatic or epilepsy. Here you're seeing that tonic extension, and then moving over to the other side. You're seeing a lot of redness in the face. That's an autonomic component as well. You're hearing those you're hearing those beeping in the background. So this would be classified as a tonic seizure. This child's EEG, not normal. When we looked at it, the EEG is very helpful. It's sort of in that burst suppression kind of pattern. And the seizures themselves helped us. So this is, just to orient you, blue is left, red is right, so temporal, central, central, temporal, and then a string going from one ear to the other ear. You're going to see a seizure start here, and it's basically recruiting spikes that become a lot more obvious over time. This one would be picked up on amplitude EEG, but if this were just in the temporal lobe, it would not be, because your amplitude EEGs are just looking at C3, C4, so the central chains. And so fortunately, this one would be picked up on that, but not every seizure in a neonate is really going to be picked up on HIE, or is going to be picked up on your amplitude EEG. Those recruiting rhythms then kind of stop. And those are exactly how they looked over and over, occurring dozens of times a day. This is a study we did out of UCSF, published last year, looking at these different presentations of seizures. And if you can remember that tonic seizures in a neonate mean that there's typically a genetic cause, then you're doing good. Typically, channelopathies, these are genetic-based epilepsies. Tonic seizures are really, we really see this. Tonic seizures in a neonate typically tell you there's a genetic etiology. If you have HIE or stroke, it can be much more varied. Stroke, clonic seizures are much more likely to occur than the other types, other etiologies. Myoclonic seizures typically thought to be associated with inborn errors of metabolism, which of course are also genetic, but they have a particular flavor. But again, the semiology can really guide us. So if you see a neonate or an infant with tonic seizures, that's really telling you that there is likely going to be a genetic etiology. In this particular patient, we were able to do gene panel testing on a research basis, I believe, back then. And they had a gene variant in KCNQ2. This is a voltage-gated potassium channel. And initially, one of the first genes described in epilepsy, discovered in 1998 in newborns with benign epilepsy, now what we call self-limited epilepsy. And then later determined, so we discovered the gene in 1998 associated with benign familial neonatal convulsions. So kids come in, they seize, their EEGs are normal, their backgrounds. They stop seizing a few months later and they're fine, runs in families. It wasn't until about 2012, 2013, where we just found out that there was a more severe phenotype of this disorder. So not self-limited or benign, but associated with a very severe type of developmental epileptic encephalopathy. There's not been really a genotype-phenotype correlation that we found with this. Unfortunately, it's just, the ones that are occurring that are more severe are typically de novo. And so the way this works, so these two, if you guys all remember action potentials, not that you should, but if you do remember, right, you reach your resting membrane potentials at like -70, -80 millivolts. When you get an action potential generated, you open up these channels, these ion channels, Sodium rushes in, you depolarize, and you have to repolarize. And these voltage-gauged potassium channels are incorporated or help reestablish that baseline resting membrane potential. The loss of function of these potassium channels leads to a reduction of the potassium currents, and these are the ones that are getting you back to that negative resting membrane potential. So when you inactivate them, you actually are causing hyperexcitability, which makes it more likely for these new seizures to occur. Our patient tried tons of different medications, none of them helped, and then we began a sodium channel blocker. And this is not a medication that's typically used in the neonatal ICU at that time, and seizure stopped relatively quickly. At one of the small conferences that we all go to, we were going through challenging cases. A few of us had kids who looked exactly the same, exact same tonic seizure. We didn't know what the genetic diagnosis was quite yet, but we recognized that all of them responded to sodium channel blockade. This voltage-gated sodium channel blockers like phenytoin, dilantin, carbamazepine, Tegretol, oxcarbazepine, which is trileptal, now you can glucosamine, Vimpat, they worked. Nothing else seemed to work. And so we put together a paper looking at lots of different patients, looking to see their seizures, all which were usually at least 10, 20, 30 different medication trials. You try a sodium channel blocker, all goes away. So it was just a really cool way to see how team science can occur by collaborating with people at different institutions, because again, these are rare epilepsies. We may see just a couple here every year, but you take this and you add the people from different institutions coming together, you can put a case series which can really help. Interestingly, my brother was a physical chemist. He went into industry because he's probably smarter than me. And he was doing because I was interested in this, he did some crystallography of the potassium, KCNQ2. And the KCNQ2 channel and the voltage-gated sodium channels are linked. And so it's likely that this voltage-gated sodium channel blockade actually can induce a morphological change or in the potassium channel itself. And that is what, so although if you think about it mechanistically, it may not make sense. If you look at the crystal structures, it seems to work. So it's another cool thing where if you have a family member and you try to get them jazzed about the stuff you're doing, it can potentially help. He never published it because he went to industry and doesn't need to publish it. So it's there. Now, I'm talking about sodium channel blockers, but there is actually a precision medicine drug that can target KCNQ2. It's called Ezogabine or Retigabine. It was on the market about 10 years ago. It was used in adults with focal epilepsy. It had this pretty terrible side effect of causing adults with their fingernails in their eye, their sclera, would turn blue. So it got a black box warning, and then no one prescribed it again, and so it was pulled. Not because it was dangerous necessarily, but because no one was prescribing it. This particular drug actually opens that potassium channel back up. So it is directly undoing the effects of the mutation, the variant, and potentially could be helpful, right? So there is a clinical trial kind of going on looking at this medication in it. Before it was kind of pulled, we were able to kind of do some case series on this, looking at kids with KCNQ2 epileptic encephalopathy, different variants. This is in vitro modeling in oocytes of particular variant channels. You can see, even though we have a drug that directly undoes the genetic change that's occurring, it's not always effective. So you have placebo. These are different currents. So this is a normal channel, and you can see that Retigabine works with some of these variants, but not others. And it's just important. So even though it is precision medicine in a way, we have a drug that's directly targeting the genetic change. It doesn't work for everybody. And it's more than just sort of brain concentration. It's because these networks are a lot more complicated than I think what we're able to understand right now. We then tried, okay, so, we can help with their seizures somewhat. The sodium channel blockers are great at getting these seizures under control. Ezogabine, Retigabine helps maybe kind of the same way, but we're talking about stopping the seizures when there's something else going on, right? They're having intellectual disability as a result of both their seizures and what's happening in between those seizures, right? That epileptic encephalopathy. So although these drugs are stopping the seizures, are they helping the overall phenotype? And so we used Retigabine, and this is a case series using Retigabine in these kids as early, as 3 months after diagnosis to 2 years after diagnosis. And it didn't help with development. So even though we were giving it to them, we were stopping the seizures, it didn't really help with their development. And so, we thought we'd really be helping these phenotypes, but, thinking back doesn't make sense. Because when you ask moms, when they see these seizures, they'll tell you their kids were doing those movements in utero for the last few weeks. So you have a channelopathy that is then likely totally creating networks that are not supposed to be there, or malformed networks. And so just using a single molecule drug that's sort of putting a band-aid on that channel may not be able to undo everything that had been happening during development, right? Brain development is occurring in, first and second trimesters. And so those gene channels are already there. They're already being, they're already causing these malformed networks. And there is a trial for this going on. Xenon is the company that's doing it. They're looking at reusing Retigabine and Ezogabine again and a little bit more, hopefully to get it approved for this population. Again, I think it's going to be very helpful for their seizures, not as convincingly helpful for their overall neurodevelopmental phenotype. They're not really looking at that as an outcome because that's harder. It's a lot more costly to do neuropsychological testing over and over again. But I think that's important as you start seeing different trials that come out, is what is their endpoint, right? Is it just seizures? Well, I told you I can get the seizures gone. That's really not what we need right now. We need to figure out how to do better than that. I'm going to present another case, which I think should hopefully shed light on how we potentially could get to undoing some of those malformed networks. Another baby, term, started seizing around 1 day of life. Similar type of seizure, right? So our nurses are fantastic. They get the kid on video so we can see the seizures. Again, you're seeing that arm raise, other arm raise. Looks very similar, right? This is a tonic seizure in a neonate. And so when we were describing KCNQ2, we thought all tonic seizures had to be KCNQ2 as we started to do genetic, right? But that's, we were doing case ascertainment bias. We were just we weren't testing everybody. We're just testing. As we started doing genetic testing more frequently in the neonatal ICU and the PICU, we learned that these phenotypes are a little bit more varied and the genetics behind them are also varied. So what was different from that particular child than the one I showed you before is their legs often crunch up. This is this child now a few weeks later, not wrapped. The tonic component also involved the legs. So they do this, these kids do this crazy crunch with their legs. And again, I was at a conference, smallish conference. We're going through some difficult cases. 3 of us, again, had kids who looked exactly the same, who did this ridiculous crunch up. And all of them had the exact same genetic diagnosis. It wasn't KCNQ2, it was that other one I mentioned before. So again, a tonic seizure, slightly different flavor, but tonic, makes you think genetic. Their EEG background, not as severe as the one I showed you before, right? It's not as severe with that burst suppression, certainly abnormal for a term neonate. The seizure you're going to see, you see this recruiting rhythm coming more centrally. Again, this would be picked up by an amplitude EEG because it is in that central brain region. This recruiting rhythm that comes out, followed by some 1 to 3 hertz slowing. So recruiting spikes, slowing after, and then some profound attenuation. And we found that these kids all had genetic variants in SCN2A. And so up until we kind of helped describe this in maybe like 5-6 years ago now, we thought this was, again, a gene change that was only associated with benign or self-limited neonatal epilepsy. So kids who would develop seizures early on, grow out of them a few months later and be totally fine later on. So another gene that was discovered, this one 2008, so 10 years after KCNQ2. And then more recently, we've learned that the phenotypes of these disorders are much more varied. Originally, again, we were just testing the most severely affected kids. So we thought everyone with SCN2A or KCNQ2 had to have a really severe phenotype. As we do genetic testing more and more, we recognize that these are one genes with many different multiple syndromes. And you can have a severe, this is describing SCN2A and the multiple different phenotypes. You can have neonatal or infantile onset, childhood onset, adult onset disease with this particular gene. You can have an infant with a benign form or the intermediate or the severe form. You can have intellectual disability that's associated with it or not, and then a movement disorder that can also be associated. Typically, the movement disorder is more associated with the childhood onset, but certainly can be there in the infantile onset as well. When you think of one gene multiple syndromes, you look for things like genotype-phenotype correlations. We have yet to find them, really. There's not been a particular signature that's helped us. And so it may be that it's just not SCN2A, and it may be that it's SCN2A plus other different association genes that modify the phenotype in particular ways. So we're still learning about that. Interestingly, as we were learning more about this, we also came to the conclusion that this particular sodium channelopathy also responded to sodium channel blockers beautifully. These are different graphs showing the use of sodium channel blockers, phenytoin, carbamazepine, oxcarbazepine, in these kids with SCN2A early onset neonatal epileptic encephalopathies. And just, you can see that we can get seizure reductions often in the kids who have epilepsy onset in the first months of life respond quite beautifully, many of them having seizure freedom. As you get older and you have this, they become a little less affected. And again, it's because these phenotypes are different, what's happening is different. And so sodium channel blockade, again, is another very helpful in this population as well. And this is why now in our neonatal seizure protocol, neonatal status protocols, you'll see one of the fourth, fifth line things that you'll see in it is using a sodium channel blocker, like trileptal or tegretol, oxcarbazepine, carbamazepine, in that to see if it is an epileptic encephalopathy, can we get the seizures down? So this particular diagnosis, again, tonic seizures, typically around 1 or 2 days of life. Interictal EG, not as severe as the kids with KCNQ2, but again, it's a range, and they also respond to sodium channel blockers. There is a trial going on that we found out, this is wrong slide, but the same company has a molecule that directly targets that particular variant of the sodium channel. So it's a specific sodium channel blocker just for that particular SCN2A and SCN8A. And so they're trialing it. But as I said, I can make the seizure stop with any sodium channel blocker. So the question is, can I undo any of the phenotype with a more selective sodium channel blocker? And again, I think if you take a step back and you think, okay, well, these kids have different networks than a normal term kid or kid without this particular genetic change. Will a selective sodium channel blocker work? I don't think you're necessarily going to undo what happened, but I think it's worth. We certainly have to look at it as long as we're using the correct outcomes for that. Right, just looking at seizure counts is not helpful. We need to do repeat neuropsychological testing, even though it's more expensive. We need to do that. So hopefully, I've sort of convinced you at this point that finding a genetic etiology does influence management, right? At least I've given you 2 cases, but there's several other. All those epilepsy syndromes I've kind of showed you earlier on in the neonatal and early infantile period are starting to have precision medicine approaches. Fortunately, again, we can stop the seizures, but we need to think about what else we can do for their intellectual disability. If you were questioning, well, Adam, you cherry picked, you just showed me 2, right? Well, I can tell you that genetic testing in epilepsy does help. This was a study published late last year, just a few months ago in JAMA Neurology. It's a cross-sectional study of 418 patients who got a genetic diagnosis from targeted gene panels or microarrays. And what they did was they asked patients and providers, did this change management? And 50% of the time, they said yes, parents and providers. Interesting, the responder rate for these surveys with parents was like 95%. I've done survey studies and kind of hit my head after a while because it's so hard to get even 20% of people to respond. But they got 90% plus people to respond because I think they wanted to show that this actually does help. Not only did it help, but the things that it helped with, right? It changed medication usage. Maybe they referred to an epileptologist. Maybe they recommended surgery. Overall, though, these changes resulted in a decrease in seizures in 2/3 of patients, and 1/3 were completely seizure-free. So genetic testing, not just in the neonatal period, but really throughout childhood, for epilepsy at least, really can change management and do so in a really meaningful way. So moving on to research that we're doing here, some of which is funded, some of which we're really actively trying to get funded is, let's say, like I said, we know that these are happening. We know we have drugs that can treat the seizures, but can we do something else that actually modifies epileptogenesis in this period? So disease modifying therapies, right? So not just precision medicine, but disease modifying. And so this is where we've been moving towards. And this is a paper a couple of years ago now, looking at oligosense nucleotides in kids. Well, this is a mouse model of SCN2A, gain of function, which is what mimics the clinical. Sorry. There we go. What they did was they injected these ASOs in their mouse model. Here is the control ASO, is in orange. Green is the active ASO. And they did it at different time periods. P1 would be a little bit funny because P1 would just more likely the equivalent of when we would be doing this in a child would be pre-14, 16. And you can see, compared to controls, you are improving survival, you're decreasing seizures, and their behavior actually improved as well. So behavioral testing actually improved over the course of this treatment. And this was just a single injection. Repeated injections seem to help even more. So antisense oligonucleotides, where you're actually knocking down or knocking up an allele, seems to be, at least in animal models right now, a way to potentially undo some of the effects of this. So you're not just sort of putting a band-aid on the channel, but actually hoping to undo it. So you increase expression of the good one. Right now, these are tough because in our populations and neonates, these are N of 1 trials. And N of 1 trials are hard to fund. You need to work with either nonprofits or for-profit companies who are going to help you make them and then get them, each of them is an IND. So it takes a lot of effort. And getting the clinical research coordinator effort to do this is really something that we are going to have to rely on philanthropy because it just doesn't seem like, at least in the NDS, they're super interested in funding this at the moment. Perhaps when we are able to show that there is benefit and, with appropriate kind of follow-up testing, we might be able to demonstrate that this is helpful, not just for a few, but really for a lot. The question is going to be two. There's, antisense oligonucleotides come in two flavors, allele specific and patient specific, right? So some of these like SCN2A, you can do allele specific ones. So one ASO potentially help many kids. For KCNQ2, the gene is such that each individual patient is going to need their own kind of ASO therapy. And that's going to, I think, also going to be potentially alter the way we kind of use this. Right now, Dravet syndrome, which is related to an SCN1A, another sodium channelopathy. These are kids who develop seizures in the first year of life. And then the intellectual impairment doesn't start for another few years. So they're seizing, the seizures get worse, the intellectual disability gets worse. And so there's actually a window where you can potentially really modify that phenotype. And so there's a study called the Monarch study that's occurring that we're I think we're the highest recruiting center right now. This is using an antisense oligonucleotide, administering it intrathecally, and following these kids. So we're actually giving them something that it doesn't turn down the negative, variant copy. It increases expression of the good copy. And the data is, we'll see what the data shows in a few years, but this is sort of, I think, where we're moving is hopefully we can get something in that not only treats the seizures, but hopefully undoes the channelopathy in a way, and hopefully lets those networks either heal or start to repair themselves. The question is for these early onset ones. So Dravet syndrome, very nice, right? You get diagnosed between 6 to 12 months of age. You have a couple of years before they're really going to start to have worsening development. That one, you have a couple year window. For these early onset ones, like I'm saying, their brains may have just not formed correctly. The networks have not formed correctly. And so what are you going to be able to intervene in a meaningful way? Again, the animal data suggesting that you can. I think it's something we have to see in the clinical side, whether that really makes sense. There's some other precision medicine drugs that are going through trials right now. But I think, again, for us, if I can stop the seizures, I can stop the seizures. A precision medicine drug that just is a little bit more specific for a channel may not be what I really need. I need to undo, I need to change that way that channel is being expressed. And that's where oligosense oligonucleotides are coming out. So we have patients that we're starting to enroll. Again, it's very costly and it really needs to be driven by philanthropy, unfortunately, at this time, because insurance doesn't cover it. UCSF doesn't cover it. They have no interest in cover it with their budget cuts right now. So it's really philanthropy that we're using this in, but it's got to be centers like this that do it in order to get this going. So my research is more translational, and certainly I think this is important, so we're doing it, but a big part of our fundraising is trying to get this going so we can get this through to patients who need it. They really are the better. Now, the future of genetic testing. So I talked about these different genetic tests. Long ago are the days where it took a month or two to get these test results back. You can get test results back in 4 days. A target panel, a genome, 4 days. All you have to do is you call your rep. So it takes a day or two to get the sample to wherever it is. If you overnight, it'll get there the next day. It takes half a day to isolate the DNA, purify it. It takes half a day to sequence it. And the rest of the time is bioinformatics. Where you on their queue is when you get it done. But if you tell them that this is an important case, it's a baby, for example, or an infant, you can push them to the top of the queue. If you don't get the response you want, then use the tried and true. Can I speak to your manager? That usually has gotten it for me. So you can get these tests done. You just have to call them and be like, this is important. Put this at the top of your queue. This is not an outpatient. This is an inpatient, or this is someone who I think we may be able to do something that can really target their disease in a way that we don't have the time to wait a month or two. So 4 days is the turnaround time if you call them. Ultra rapid nanopore genome sequencing is like 2 days. So you can decrease that time from 4 to 2 days. The other part of what we're, at least in epilepsy, is really focusing on is the research I do is on epigenetics. So looking at the role of microRNA. So you have these genotypes from exomes and microarrays. And then we're doing small non-coding RNA sequencing to look at how these may play a role in both protein translation related to the genome as well as the epigenome. This is also methylation testing is in that realm as well. Post-legatic somatic mutacisms are tough. Some of the super malformations, that's what we're thinking about. And so what we're also doing now, so this was a pilot study that we did, was looking at genetic testing in kids at risk of epilepsy. So you have the kids with acute symptomatic seizures. If you have an acute symptomatic seizure related to HIE or related to stroke, we can tell families that there's about 15-20% chance that that child will have another seizure and get diagnosed with epilepsy in the first few years of life. That's not a very fun number to give people. Parents really want less than 5 or greater than 95. That's helpful. 15 and 20, it's not 50-50, but it's not great. And so what we were doing is using genetics, so using targeted gene panels to help us identify or hopefully risk stratify. So this was a pilot study, fortunately funded by CTSI, to look at this. And we found that, the kids who did develop epilepsy did have genetic variations in those epilepsy genes. They weren't the channelopathies, but they were genes that we know are associated with epilepsy. And so the majority of those kids who developed epilepsy after acute symptomatic seizures from brain injury had a genetic change in one of those variants. The kids who did not develop epilepsy did not. And so it was a pretty cool proof of principle study that then Hannah, Elliot, and I have an R01 now looking at this, and we're doing this in, I think, 8 different centers throughout the United States where we're doing targeted gene panel testing, microarrays, to get sort of a genotype risk factor score and hopefully better predict those kids at highest risk. And again, if you have a window where you have acute symptomatic seizures, you don't develop epilepsy for a year, 2, 3, that is a modifiable window. And so the research we're doing with epigenetics, inflammation, are hopefully going to provide us with different therapeutic options that could potentially help prevent the epileptic phenotype from developing in this population as well. So that's sort of our 5 to 10 year kind of plan. So hopefully preventing epilepsy or preventing the progression of epilepsy who doesn't already have it, so that we're not talking, we don't have to talk about second, third, fourth anti-seizure medications. I mean, that's the goal. Epilepsy stinks. It is just terrible. Having unpredictable seizures all the time affects the family unit in ways that we're paying more attention to now, but it's just a really tough disorder. So take homes for this talk: electroclinical phenotypes really help guide workup and management. Again, we're here at UCSF where we have neonatal neurologists and specialists here, but not every place has it. And truly, not every neurologist may know about this type of testing and how you can do it. So it really, if you're here, fantastic. But if you're traveling somewhere or you go somewhere else or even talk to other places, they may not have that same sort of information. So it's important to know that and continue teaching people, because I think the more commonplace we make genetic testing, the more likely we are all to be able to interpret it. I don't know. Did people need to consult hematology 80 years ago when CBCs were developed? Hopefully not, but if they did, right, eventually we stopped doing it. I'm hoping we get to the point where we can do these targeted analyses and not have to consult clinical genetics every time. Again, we know that their bandwidth is very tight. And so utilizing them for consults when we really need them, I think is going to be important. Resource utilization, there's not that many of them and they're going away. And again, incorporating indirect EEG findings, your seizures, clinical seizures, EEG seizure, semiology, using the video, help with diagnosis, and hopefully I've convinced you can also help us with treatment management as well. Also, neonatal seizures are not just one flavor. So if you see tonic seizures, right, you really should be thinking genetic testing. If your neurology consult hasn't told you to do that, you should be like, hey, is this someone we should do genetic testing in, right? Push that, right? This is something that it's a group that's treating this patient. And that electroclinical phenotype can help you both with etiology and for guiding treatment. And again, precision medicine, we have it. We're not quite there, but we're trying, and we're actively trying, and we're getting closer to prime time, hopefully in the next 5 years. So thank you, big thank you to lots of people who helped with this. And as you can imagine, these N-of-1 studies, doing epigenetics in this population, it takes a lot of people. And so these rare diseases take large collaborations, and I've been very lucky where I am to get tied in with Donna, Hannah, lots of people in our epilepsy team that have really helped connect me with the right people to get these multi-center collaborations off the ground. So thank you.
Thank you, Adam. Can I just ask a question? Is it University of Washington, right? Not Washington University.
It's University of Washington.
Yeah,
sorry.
okay. Just to clarify, I was
Yeah.
like, I think those
So
are
that is correct. University of Washington. So yeah, Sunny Jewel there is
Yeah,
just been a fantastic
Brian
collaborator. Yeah.
Jim had a question. Jim, do you want to just unmute and ask your question? It was in the chat.
Yeah, I think that most companies, when you order Target, they do a panel, but they only report the panel, and it's germane to if the panel's negative, reanalysis, things like that. Is that correct?
It is correct, like 5 years ago. Now, the panels have been developed as such that we really have, we don't know every epilepsy association gene, but we know a lot of them. And so the reanalysis part isn't as necessary because we've identified, some of these panels now have 1,000 epilepsy genes now. And so we're not reanalyzing them. So it's really, this is why I don't even order exomes on these kids. I'll do the panels because they're so robust. You're getting deep sequencing. That was an issue before as well. I'll do a microarray if that's negative, and then trying to get a research genome. And those will keep reanalyzing because we need to keep discovering more and more.
And the other question was about the route of administration of the antisense oligonucleotides, but you indicated later on that it was intrathecal. Thank you.
In the animal models, it's intraventricular, in cerebroventricular. In patients, it's it seems like even though we're doing intrathecal, it's getting into the brain in enough quantities. But yeah, for the targeted panels, just getting back to that, they do an exome capture, but they don't analyze it as an exome. So they have the exome data, but they're not analyzing it in that way. And
well, that's
so
precisely
that's
precisely what I said.
Sorry. So, but they don't reflex anymore. So that's something you have to ask for. And it's actually, if you're not a geneticist, reflexing to do a whole exome, what do I do when I get a patient who has a BRCA variant? I can't consult them. And then I refer them to genetics, and it's 6 to 12 months right now. And we're losing, our genetics teams is fantastic, but we're losing them to industry, and that's not going to change. And it's happening everywhere. So, we can debate whether a BRCA variant is important in a 1-month-old or not, but it adds time to that. But yeah, it's an exome capture.
Thanks very much. Nice talk.
Thank you. And if anyone has generous family members who want to donate to us to get these done, please let me know. I feel like all I do is ask people for blood and money at the moment.
I think
but
Matt's volunteering. No,
I love it. Thank you, Matt.
Matt says really cool work. Keep it up.
Yeah, I thought the inflammation stuff I do was tough initially because biomarkers, always have criticisms and fine. But then as I'm doing the biomarker stuff and also trying to do the Center of One stuff, it's like, philanthropy is really unfortunately where we need to move.
Yeah. Okay. Any other questions for Adam or discussion point? All right. So I just want to mention next week we're staying, or 2 weeks, we're staying on the neuro theme. It'll be Yvonne Wu from Child Neurology. So hope you all can join us. Thanks so much, Adam.
Thank you. Bye, everybody.